Good morning and welcome to today's New York City Council hearing for the Committee on Health, joined with the Subcommittee on COVID and Infectious Diseases. At this time, we ask that you silence all electronic devices, and at no time are you to approach the dais. If you would like to sign up for in-person testimony or have any other questions throughout the hearing, please see one of the Sergeant-at-Arms chairs. We're ready to begin.
Thank you. Before we begin, I want to say that we've been joined by Council Members Williams, Zhuang, Narcisse. We have Chair Moya, Marmorato. Anybody online? No. Okay. Good morning, everyone. I am Councilmember Lynn Schulman, Chair of the New York City Council's Committee on Health. Thank you all for joining us at today's oversight hearing on detecting, preventing, and responding to public health emergencies in New York City. Thank you to Chair Francisco Moya of the Subcommittee for COVID and Infectious Diseases for holding this hearing with me today. We are also considering 7 resolutions at today's hearing. Resolution 330 by Councilmember Chi Osei, Resolutions 642 and 650 by Councilmember Crystal Hudson, Resolution 650 by Councilmember Tiffany Caban, and 3 resolutions from me. Each of these resolutions calls for bold action at the state and federal levels to make our city a healthier and safer place to live. Before we discuss this morning's oversight topic, I want to highlight my pre-considered resolution calling for the restoration of state public health law, Article 6, public health funding for New York City. In 2019, the reimbursement rate for New York City was reduced by 16% from 36% down to 20%. And this cut has yet to be reversed. The loss of funding resulting from the reduced reimbursement rate has led directly to a loss of funding for essential on-the-ground community health programs in New York City, including family and reproductive health care, communicable disease control, chronic disease prevention, community health assessments, and emergency preparedness. Assembly Bill 2705, introduced by Assemblymember Jessica Gonzalez-Rojas, and Senate Bill 4801 by Senator Gustavo Rivera would restore the reimbursement rate to no less than 36%, ensuring the full restoration of these programs and helping DOHMH and our city partners to build a healthier New York City. It is crucial that the state advance this life-saving legislation as soon as possible, which will restore millions of dollars for critically needed health services. Today, we are checking in with the Department of Health and Mental Hygiene on how it is responding to the many recent developments in public health happening nationwide. Most prominently, bird flu has spread across the United States, no pun intended, with DOHMH detecting the H5N1 virus in birds in New York City last week. While there have been no human cases of H5N1 in New York City or elsewhere in the state, and no human-to-human transmission has been detected from H5N1 anywhere in the country, we must remain vigilant and ensure that protocols are in place to keep New Yorkers safe. Meanwhile, we've seen reports of a measles outbreak in West Texas and tuberculosis in Kansas City, sparking concern about whether enough is being done to eliminate misinformation and educate families about the importance of childhood vaccinations. In addition, the United States is facing the worst flu season since 2009, with hospitalizations in New York State at their highest level in at least 4 years. And moreover, this past weekend there was an Ebola scare in New York City. While it turned out that the information was false, it highlighted issues pertaining to the new federal cuts to the CDC. These recent events come at a time of immense uncertainty and rapid changes in how our federal government approaches public health. No longer can we rely on our federal public health institutions to utilize best practices and follow the science when they adopt new policies impacting the health of millions of Americans. Instead of strengthening our disease detection and prevention partnerships across the globe, the United States has begun the process of leaving the World Health Organization, jeopardizing our ability to detect emerging outbreaks and adequately prepare for future pandemics. Instead of ensuring that healthcare providers and researchers have access to a comprehensive database of critical public health information, hundreds of federal agency websites from the CDC to the FDA to Health and Human Services remain unavailable, hampering the ability of medical professionals to access the latest information and provide the best care. This is particularly alarming as it relates to removed information and guidance for people living with HIV. And instead of promoting childhood vaccinations and educating Americans on the importance of getting regular immunizations against preventable diseases, this federal administration has appointed a longtime vaccine skeptic and conspiracy theorist to lead the Department of Health and Human Services, threatening access to life-saving immunizations and medications that our society has counted on for decades to keep us healthy. And by the way, yesterday, the new HHS secretary said that he was going to re-examine the vaccination schedule for the United States. At this time of uncertainty, it is more important than ever that we can count on our local and state government officials to promote New Yorkers' health and well-being, and that our public health agencies rely on science and evidence, not politics, in their approach to public health policy. DOHMH is the largest and most prestigious public health agency in the country. Every day, the agency works to protect and promote the health of every New Yorker, and that work is made possible by thousands of public servants who work tirelessly to keep us healthy. This work is essential. You are on the front lines, but you're now also one of our last lines of defense. DOHMH must have the tools and resources necessary to plan for and respond to the next public health emergency, even and especially if our federal government is unable or unwilling to do so. As chair of the Health Committee, I have advocated and will continue to advocate for those resources. I look forward to a robust discussion of these efforts. I want to conclude by thanking the committee staff for their work on this hearing, committee counsels Chris Pepe and Sarah Sucher, policy analyst Joshua Newman, and the finance staff Danielle Heifetz and Florentine Kabor, as well as my team, Jonathan Boucher, Kevin McAleer, and Abigail Zucker. Before I turn the mic over to Subcommittee Chair Francisco Moya, I want to mention that Dr. Morse is one of the best commissioners, interim commissioners that we've had at the Department of Health and Mental Hygiene, and she has raised the bar for a lot of the agencies in the city. I now turn the mic over to the Subcommittee Chair, Francisco Moya.
Thank you, Chair Schulman. Good morning, everyone. My name is Councilmember Francisco Moya. I'm the chair of the Subcommittee on COVID and Infectious Diseases. Thank you for joining us at today's important hearing on detecting, preventing, and responding to public health emergencies in New York City, as well as on numerous health-related resolutions. As we all know, infectious diseases are ever-present challenges that demand vigilance, swift action, and an adaptive approach. The COVID pandemic made this clearer than ever, but it also highlighted the vital importance of our public health agencies in responding to emergency health threats. The city's health department plays a critical role in detecting, tracking, and responding to infectious diseases both here in New York City and in coordination with national and international health agencies. In the wake of the COVID pandemic, it is more important than ever that we have access to accurate, up-to-date health data and effective monitoring tools. This includes waterway surveillance, which has proven to be an innovative tool in identifying outbreaks in New York City before they escalate. However, as Chair Schulman mentioned, I must acknowledge the recent confirmation of Robert Kennedy Jr. as HHS Secretary. While this position is vital to guiding national public health policies, Secretary Kennedy's long history of spreading misinformation about vaccines raises serious concerns. His public statements have consistently undermined the trust in vaccines despite overwhelming scientific evidence of their safety and efficacy. As we look to the future of vaccine guidance, and particularly childhood immunization schedules and vaccine guidance during outbreaks, it is critical that we ensure that our government continues to prioritize the protection of public health and safety of our most vulnerable populations. Here in New York City, we cannot afford any rollbacks in vaccine policy or any confusion that undermines our efforts to protect children, older adults, and others who are at most risk from preventable infectious diseases. I'm interested in learning how the city's health department plans to respond to any shifts in federal guidance and how we can work to combat vaccine misinformation at the local level, ensuring New Yorkers continue to have confidence in the vaccines that protect us all. I look forward to hearing from the administration on this issue, and I wanted to conclude by thanking Claire Schulman, my fellow council members, for being here today. I would also like to... I said Chair Schulman.
Oh, Chair, I thought you said Claire.
No, not Claire Schulman. I said Chair Schulman. We're from Queens, so that's why it may resonate, but no, Chair Schulman. And my fellow council members for being here today. I would like to thank the subcommittee staff, my own staff for their work on this hearing, and I now turn the mic back to Chair Schulman.
Thank you, Chair Moya. We've been joined, I want to point out, we've been joined by Council Members Caban, De La Rosa, Menon, and I want to ask Councilmember Caban to give a statement on her resolution being considered today.
Thank you, chairs. I am here to speak about Resolution 650 of 2024. The Department of Health and Human Services oversees key federal health agencies like the Centers for Disease Control and Food and Drug Administration. The federal government, particularly the FDA and the CDC, played a critical role in combating the COVID-19 pandemic, leading vaccination efforts, including the high vaccination rates right here in New York City. The Trump administration has threatened all modern advances in public health by appointing the vaccine and science skeptic, Robert F. Kennedy Jr., as Secretary of Health and Human Services. Kennedy has promised that, quote, nothing is going to be off limits in his administration. Last Friday, the Trump administration told thousands of employees across HHS that they'd be losing their jobs. That includes potentially all probationary employees. These cuts will have particularly devastating effects on the basic protections and services offered by FDA and CDC. In light of these political realities, the resolution urges the federal government to continue its science-based public health advocacy, recognizing the importance of protecting public health. Thank you.
Okay, I want to recognize we've been joined by Council Members Ariola and Rivera as well. I am now going to read a statement on behalf of Councilmember Crystal Hudson regarding her resolution. Good morning. Thank you, Chair Schulman, for reading the statement on my behalf regarding any resolution the committee is hearing today. Regarding my resolution. Resolution 642. The CDPAP program is a lifeline for many homebound older adults that ensures they receive the care they need from health aides without forcing them to move to expensive residential care facilities. My resolution would call on the state to enact common sense legislation from Senator Gustavo Rivera, Senate Bill 1189, that creates a licensure program for fiscal intermediaries where they must show their compliance with various laws and could have their license revoked for violating license terms or Medicaid-related laws. Licensing has proven to work in every other profession and industry, with the council most recently passing licensing requirements for the hotel industry. This will meet the needs of both the state and advocates by ensuring anyone engaging in fraud is removed from the program while permitting multiple fiscal intermediaries to operate and ensure continuity of care. Thank you. Council, now in accordance with the rules of the council, I will, oh, that's you, sorry. I will now turn it over to committee counsel to administer the oath to the representatives from the administration.
Thank you, Chair. Good morning.
Good morning.
Now, in accordance with the rules of the council, I will administer the affirmation to the witnesses from the mayoral administration. Please raise your right hand. Do you affirm to tell the truth, the whole truth, and nothing but the truth in your testimony before this committee, and to respond honestly to council members' questions?
Yes.
You may proceed.
Good morning, Chair Schulman, Chair Moya, and members of the committee and subcommittee. I am Dr. Michelle Morse, Acting Commissioner of the New York City Department of Health and Mental Hygiene. I'm joined here today by my colleague, Vasudha Reddy, Deputy Director for the Bureau of Communicable Disease. Thank you for the opportunity to testify on New York City's response to public health emergencies. Together, New York City lived through the collective trauma of the last major public health emergency. We know the stakes are high. But the New York City Health Department has been responding to public health crises since our founding 220 years ago. Crisis response is at the heart of what we do in public health, but each emergency is different. Our city and our agency have learned many lessons since the first case of COVID-19 was confirmed nearly 5 years ago in New York City. In 2022, during our response to both the COVID-19 and Mpox emergencies, the New York City Health Department committed to improving its emergency preparedness. And in light of the significant racial inequities we saw in health outcomes during the height of the pandemic, we understood the need to prioritize equity in our strategic planning. We started by building a shared definition of equitable response readiness with the input of more than 1,000 health department staff. The next step was building a blueprint that embeds equity, trust, agility, and resilience into our agency's architecture. Over the next few years, we will be implementing that blueprint across our agency. When the next emergency hits, this blueprint will ensure that we have what it takes to prioritize disproportionately impacted communities, to collect, analyze, and share public health data in close to real time as possible, and crucially, to operate as part of a larger public health system with partners at all levels of government, local, state, national, and international. I underscore the last point because public health is global. Communicable disease is not constrained by borders. From HIV to COVID-19, we have seen time and time again just how quickly local public health challenges can become global crises. Our health department has a strong system of disease surveillance, which is population-level practice of data collection and analysis. Surveillance systems are used to establish and monitor patterns of disease, identify outbreaks, and inform strategies for prevention and control. The larger system is paired with the work of disease investigation. This is the process of collecting information about a person or a group of people who have suspected or confirmed cases of infectious disease. Investigations can include interviews with the impacted person and their healthcare provider, reviews of medical records, and contact tracing. Those systems, however, are reliant on national and global public health infrastructure. We need timely and accurate information from the Centers for Disease Control and Prevention. We rely on the WHO, the World Health Organization, for access to their comprehensive surveillance of both routine and emerging public health threats around the world. New York City is the largest hub of international travel in the United States. We cannot afford to operate in a vacuum. Here at the New York City Health Department, we will continue to rely on data, science, equity, and our values to guide our decisions. We have 220 years of experience deepening our public health expertise, refining our data-driven approach, and engaging the public. For as long as this agency has existed, we've protected the health and safety of our city, supported by factual information grounded in science. We remain committed to those principles. There have been a lot of announcements and policy changes coming from the new federal administration, especially around federal funding. We are monitoring federal policy closely as it develops and planning accordingly. Approximately 20% of our budget is federally funded. That's about $600 million, the majority of which goes towards infectious disease control and emergency preparedness. We expect the federal government to honor the commitments that it made through grant agreements and contracts that fund vital public health services benefiting New Yorkers. As we prepare for unknowns in federal public health funding and possible changes in federal public health guidance, we will become more reliant on state and local dollars. Right now, New York City is also operating on reduced funding from the state. Article 6 determines the state's contribution to public health services provided by local health departments. In 2019, New York City's matching funds for Article 6 were reduced from 36% to 20%. We were the only local jurisdiction to have our public health funding cut. In the years since, we have lost upwards of $90 million per year in state public health funding. This is not just an issue of parity with the rest of the state, it's an issue of equity. New York City has the largest population of Black, Latino, Indigenous, and people of color in the state. We're also home to the most individuals with low incomes and the largest portion of Medicaid recipients in New York. These are our neighbors, loved ones, colleagues, and friends. Regardless of the federal context, our residents deserve equal access to New York State public health funding. Given the vulnerability of our federal funding, this issue has never been more important or timely. To be able to meaningfully promote and protect the health of New Yorkers, as my agency is charged to do, we need consistent and sustainable funding sources. In public health, we often see a boom-bust cycle of funding where money swells during emergencies and dries up in the intervening years. We do not invest in public health prevention. We often invest in our sick care system. As I mentioned at the start of my testimony, The New York City Health Department was founded in a moment of crisis 220 years ago. The Board of Health in New York City first convened in response to a yellow fever outbreak in 1805. For the next 50 years or so, the city only devoted time and money to public health in moments of crisis. The organization would otherwise lie dormant. We know that public health works best as preventive health. The health department's work creates an invisible shield that keeps New Yorkers safe. That is life-saving work, and it extends far beyond emergency response. It has a tangible impact on the everyday health and longevity of our community. It requires, however, a sustained investment. In 1913, excuse the history lesson, Chair Shulman and Co-Chair Moya. In 1913, then Commissioner Herman Biggs said, "Public health is purchasable." Within natural limitations, a community can determine its own death rate. In other words, we can literally buy ourselves more health and time, and over the course of history, we have. When Commissioner Biggs led the health department, life expectancy for New Yorkers was about 40 or so years, in their late 40s. Now, it's over 80 years. Though investments have created leaps forward in public health science and interventions like clean water, vaccines, and improved sanitation, we have bought ourselves decades of more life. Those investments fund a matrix of work happening across our city each and every day. More than 7,000 people work at the health department, and all of them work for the more than 8 million New Yorkers in one way or another. For example, to prevent foodborne illness, we inspect more than 30,000 food service locations for food safety, including restaurants, school cafeterias, and food trucks. To ensure that every child in New York City has access to vaccines, we distribute more than 2.5 million doses of pediatric vaccines to more than 1,000 different healthcare providers. To prevent the spread of disease, we conduct thousands of disease investigations related to certain sexually transmitted infections, foodborne illnesses, waterborne illnesses, and other infectious diseases, just like the hepatitis A one that you might have heard about a few days ago. To prevent overdose deaths, we distribute more than 300,000 naloxone kits and more than 54,000 fentanyl test strips. To meet New Yorkers where they are and build trust on the ground, we've equipped more than 5,000 community health workers to join our public health corps. To support parents who are pregnant or who have young children, we've provided more than 20,000 families with home visiting nurses, doulas, and community health workers. To support people who do not want to be pregnant, or for those who cannot safely carry a baby to term, we have fielded calls from more than 8,000 people at the Abortion Access Hub. Lastly, to celebrate the joy of new birth or mourn the loss of a loved one, we issue more than 1 million birth and death certificates annually. That's just a glimpse of our work. No matter what lies ahead, our efforts will continue to be driven by data, science, and health equity. We will defend the health and well-being of every New Yorker, regardless of their race, gender identity, socioeconomic status, ability, or zip code. And we will continue to work towards longer, healthier lives for all of our city's residents. When you invest in the New York City Health Department, that's what you're investing in. Regardless of whether we're in a period of public health emergency, our work touches every aspect of New Yorkers' lives, quite literally from birth to death. I'm so proud to serve New York City, where we are committed to upholding the full spectrum of public health services and ideals, where we declared racism a public health crisis, and where we remain committed to racial equity in all facets of our work citywide. Especially in a time where trust in government may be fragile, we owe it to New Yorkers to keep doing this work. As a practicing physician and internal medicine doctor, I'm inherently asking every patient I care for to trust me with their life. That trust cannot be given, it must be earned. Trust is gained in drops and lost in buckets. The New York City Health Department is committed to gaining your trust drop by drop. For more than 2 centuries, we've been the pinnacle of public health in the United States. That should not change now. Thank you, Chair Shulman, Chair Moya, and members of the committee and subcommittee for your ongoing partnership and support. I'm happy to answer any questions with my colleague, Sudha Reddy.
Thank you very much, Commissioner. So my first question is, there are multiple definitions at the federal, state, and local level for what a public health emergency is. For purposes of our city, how does DOHMH define what a public health emergency is, and what is the process for declaring a public health emergency in New York City?
Thank you so much for that question. One of the roles of the Board of Health here in New York City is to really work with us at the New York City Health Department to assess emergencies, assess the risks that might come with those emergencies, and determine collectively with us at the New York City Health Department and our experts what threshold may be met for declaring an emergency. Most recently, that did happen, of course, during the COVID pandemic, and we work very closely with our Board of Health here in New York City to make sure that they have the data, that we are sharing the data with them, and that collectively we can determine when we've hit a threshold of risk and a threshold of concern and need to activate additional resources or additional regulations and powers in order to protect the public.
What city agencies are typically involved in preparing for potential and future public health emergencies?
Well, that's a phenomenal question. We pride ourselves on working very closely with sister agencies across the city, as well as other stakeholders who are not in city government. We work very closely with NYSEM. We also work very closely with Health and Hospitals. We work very closely with DSS and many other agencies that would be involved in emergencies. And the reason that it's important to have those relationships, of course, is that oftentimes a public health emergency cannot be responded to by a single agency. It often requires the engagement of multiple different agencies with their own expertise and powers. And so we make it a point to have good relationships with our sister agencies because we know we would need to work together in the event of a public health emergency. We did learn that both during COVID as well as during the MPOX response. And then the final thing that I'll say is, in addition to us working closely with all of those agencies, the sister agencies, we always make sure that we're in close communication with the state health department. I am thankful that I have a phenomenal relationship with Commissioner Dr. Jim McDonald, who's a pediatrician, because we also know that we have to rely on the state in some cases and partner with them either around data or actions or other types of responses to public health emergencies. And we coordinated very closely together, for example, with the live bird market closure that just happened a couple of weeks ago.
Can you describe the type of support, including funding support, that the federal government provides to New York City during public health emergencies?
Yes, that is a really important question. I'll start by describing kind of what happened during the COVID pandemic. During the COVID pandemic, there was a really powerful federal response after a little bit of time. And during that response, the New York City Health Department was able to receive funds from the federal government to help with a number of different key activities that were required to make sure that everyone got vaccinated and that everyone had reliable public health information to protect themselves. At the end of that response, our estimate is that the New York City Health Department spent about $1 billion on that COVID response, but each response is different. And what I will say is that the $600 million in our current agency budget that are direct federal funds, those funds really build the infrastructure that we would rely on for any emergency response. That includes things like disease investigation, the data that we need to know if a new public health threat is coming. It includes our public health lab, and that lab, of course, functions 24/7 to make sure that any emerging infectious threats are tested and identified. So those are all core public health infrastructure and services that we would rely on very heavily if and when we face another public health emergency. I hope that answers your question.
Yeah, I mean, given what, and I know it's early, but given what Robert Kennedy Jr. said yesterday about changing the vaccination schedule, what are your, two things. One, what are your concerns about that? And also, how would we prepare to make sure that New Yorkers get the vaccines that they need?
Thank you for that question. We are monitoring all of the changes from the federal government and the policies and direction being issued very closely to examine how it could impact the health of New Yorkers. I'll start by saying that if the new Secretary of HHS is planning to re-examine the childhood vaccination schedule, my question would be, with whom? Is he doing that with experts? Is he doing that with pediatricians? Is he doing that with the American Association of Pediatrics? Is he doing that with public health experts who've been upholding excellent standards of science and data-driven public health for generations? I know also, I cannot predict what the results of his re-examination would be, but I would hope that he would be relying on the experts within HHS and the CDC who've been driving and leading the gold standards for evidence-based, effective public health interventions for decades. How will we prepare in the New York City Health Department? Our challenge always, of course, is we can't predict the future. It's hard to know exactly what might come of that re-examination, but what I can promise City Council and New Yorkers is that we will be continuing to make decisions based on science and data and experts in the field of childhood immunization, as we always have.
I presume that the Department of Health has liaisons that you work with in the federal government. Are those liaisons still there? And if not, do you have access to folks in the federal government right now?
That's a phenomenal question. I will emphasize that, the superpower that we have in public health is data. And data sharing and sharing data and both elevating that data when needed is in many ways the lifeblood of public health. It is very important to us that we keep lines of communication open with the CDC. There were several weeks where communication was halted completely. I find that to be very risky, and I know that many of the experts in our agency in New York City find that to be concerning. There was also a period of time when the CDC was not releasing the MMWR, which is their standard weekly updated kind of guidance, expertise, and investigations about key public health events. Those have resumed, which is reassuring. I hope that they continue to be published every week because we do rely on that guidance from the CDC to be aware of emerging public health threats and the gold standards for guidance for managing all kinds of different diseases. In terms of our communications in the New York City Health Department with our colleagues at the CDC, some of that is happening. It is not quite happening at the level that we would like, but we also acknowledge that with this federal transition, a lot has changed, and unfortunately, we're aware of somewhere around 1,300 people being fired from the CDC in recent days. So that all of those actions impact our ability to maintain open lines of communication with the CDC, but we do our best to continue to be in communication to make sure that New York City residents are safe and that we have the most up-to-date information we need to protect the health of the public.
As a follow-up to that, do you have a plan in place should communication from federal agencies or the CDC be paused again? And what I'm also asking as part of that is what alternative sources does DOHMH look to absent trustworthy clinical guidance at the federal level?
Thank you for that question. I think we are learning to be nimble and adapt in many ways to this new context, although it has been very challenging. It is hard to predict if and when there may be another pause in communications. Any pause in communications, any official pause in communications puts New Yorkers at risk because we do need to have reliable information and be in close and constant contact with the CDC. In terms of planning around how we might manage if there were to be another pause in communications and what some alternative sources of data might be. First and foremost, we are communicating very regularly with the New York State Health Department. I do think that that coordination serves us very, very well. I also am aware that the New York State Health Department recently launched a weekly global public health disease notification that helps the public be aware aware of global public health threats. And I think that that's really important. We in the New York City Health Department also do a monthly global health report. And there's more and more conversation happening amongst public health experts about how we can work very closely with partners in our region. And that would be, the states surrounding us and others to share information, to prepare and do emergency planning, and to examine how we share data with each other as well. So those conversations have started.
And in our offline communications, I know we've discussed too that the American Medical Association and others are trying to do a roundabout in terms of that kind of information. And so I assume that you guys are plugged into that as well as talking to, in addition to the region, do you talk to other cities and other parts of the country? I don't know if there's any, like I said, it's all fairly new now, but if there are any plans to get together with some of those cities too, major cities around the country.
Yes, thank you for that question. We we coordinate certainly with local and regional public health partners. We also coordinate with local hospitals and health systems, the state, as I mentioned. Other partners that we have, we're very lucky to be a part of the Big Cities Health Coalition. In fact, that was founded by a former New York City Health Commissioner. And that body is intended to do exactly what you're describing, make sure that there's information sharing across public health leaders in big cities across the nation, for us to basically trade notes about what we're seeing in our communities, what our concerns are, share examples of successes and what's working, and really, again, be innovative and nimble to adapt to make sure that no matter what changes at the federal level, we're able to do our best to protect the health of the people living in our cities. And the final thing I'll say on that is we are very also lucky to have annual convenings, and there is an upcoming convening of that particular group, Big Cities, as well as NYSACHO, which is a national organization that really helps to do coordination of public health departments as well. Excuse me, NACHO.
And so please describe how the United States withdrawal from the World Health Organization could impact global disease outbreak surveillance.
This is a really important question. I personally had experiences working with the World Health Organization when I lived and worked in Haiti and Rwanda and Liberia and several other countries. I saw the importance of the World Health Organization's presence, both their staff as well as the guidance that they offer. They also, of course, do much data monitoring and allow the world to be aware of emerging public health threats. So that impact of the World Health Organization and them having the funding they need to do those activities is incredibly important. It helps to prevent outbreaks. And so I would say that it's concerning to not be a part of that body any longer. It puts our information and data sharing at risk, unfortunately. It also means that we don't have access to as much information as we normally would have. And I will also say the World Health Organization kind of serves as a safety net health department in many ways to countries all around the world that might not have their own public health infrastructure or as much public health infrastructure as other places have. So those functions are critically important. I am concerned that we may not have access to the data and guidance that comes from the World Health Organization. And my understanding is that communication between the CDC and the WHO has already ceased, unfortunately, and people within the CDC who were assigned to partner with the WHO are no longer able to are no longer allowed to conduct those activities of coordination. So the impact of the planned withdrawal of the United States from the World Health Organization is unfortunately already being felt. Now, we also have to continue to find ways to get the information we need to protect New Yorkers and continue to find ways to make sure that information is shared. So we're exploring options for how we might be able to do that. And again, remain concerned that our country is no longer a part of this very important global public health body.
So walk me through how next year's flu shot will happen, like we put together. Can you do that for me?
I'll start,
ahead.
absolutely. So the flu shot does change year to year.
Yes.
And the way that the flu shot changes is the data from the southern hemisphere, so they're in summer while we're in winter. That data about circulating flu viruses is what informs the types of flu strains that are included in the annual flu vaccine that we take every fall here in the northern hemisphere. And so my understanding is that information can still be shared, and that the strains of flu that are predominating in the southern hemisphere will still have that information to inform what types of strains of flu will be included in the fall flu vaccine campaign here in the United States. However, as everyone knows, the flu shot is optional for most people. We strongly encourage it. It is, in fact, life-saving, particularly for our elders and people who are vulnerable to complications from the flu. So at some point this summer, we'll start to get notifications from the CDC and other bodies about the availability of the new flu shot for this fall. And come September or so, we usually start our flu vaccination information campaign and start to make the flu shot available. And there are some changes in flu shot guidance that predate the current HHS secretary, including encouraging more and more people essentially more and more people are eligible for the flu shot now. So we expect to continue all of those activities here in New York City and expect to plan for a very active fall flu vaccine campaign.
Okay, I'm going to get into the weeds for one question. How are the pharmaceutical companies that make the flu vaccine tied into that? Or I'm just curious how that works.
Yeah, that's a great question. So once it's kind of decided and the, ACIP, which is the body that helps to make guidance about vaccines, once it's decided what should go in the fall flu vaccine, the pharmaceutical companies receive that guidance and then they manufacture the flu vaccine according to what is recommended based on the strains that are circulating. And that is really standardized across all of the different pharmaceutical companies.
Okay, I just want to make one observation here, or one comment, is that I don't know if there are plans to try and facilitate better relationships or more intense relationships with the pharmaceutical companies around this issue that might help with some of this. But anyway, that aside, now I'm going to talk about the bird flu. Can you provide current statistics for the number of birds, poultry infected by bird flu in New York City?
Absolutely. I know that a lot of the New York City public and also council, you're getting lots of questions about bird flu, also known as H5N1. I think the first thing I really want to say and emphasize to the public and to council is that there is no current evidence of person-to-person spread of bird flu, again, also known as H5N1. That is really reassuring. And that means that the risk to the general public is very low right now. And the reason that I start with that is because we want to make sure that the public knows that they are currently really at low risk of any complication, of any infection with bird flu or H5N1. So there's no person-to-person spread. As you know, that's how COVID, for example, is transmitted, is person-to-person spread. We have no evidence of that for bird flu. However, we are using our surveillance system, our public health surveillance system, to make sure we're aware of where bird flu is. There is evidence that H5N1 or bird flu has actually been spreading across the country since 2021. And since 2022, we're aware of 47 wild birds in New York City who were infected with H5N1. 7 of those tests were in this year, 2025. So knowing that there is widespread H5N1 in wild birds, and also knowing that it has infected dairy cows as well, the national kind of public health surveillance system and our local New York City public health surveillance systems have worked together to monitor where is H5N1 infecting birds, wild birds, poultry, and cows. Our public health system and surveillance system is working exactly as it was designed. It does require investments and funding, of course, but it's intended to be kind of the canary in the coal mine. We want to know if H5N1 is spreading in live birds here in New York City, and this surveillance system helps us to do that. There's a similar system for testing milk of dairy cows to surveil for H5N1 there as well. So those surveillance systems, again, are the lifeblood of public health. They're going to be what alerts us to any changes and also the magnitude of spread of H5N1 in wild birds and dairy cows. But I want to emphasize again, the risk to the public is extremely low. There is no evidence of person-to-person spread of bird flu or H5N1.
Yeah, what kind of support do you have from the state, and what kind of coordination do you have in terms of the bird flu?
Thanks for that question. And again, we just want to emphasize how important that kind of partnership and coordination is, bless you, especially in times like this. So we're very lucky to have a great relationship with Commissioner Dr. Jim McDonald, who's the New York State Health Department Commissioner. We collaborated when the New York State Department of Agriculture and Markets issued an order a couple of weeks ago to close all the live bird markets in New York City and some of the surrounding counties. It was great to be able to coordinate directly with them, because then we could prepare the messaging for the public about how the closure of those live bird markets helps to protect the poultry the poultry themselves, as well as the workers who work in the poultry markets who are exposed to those birds. And so the idea is, again, that was a preventive public health intervention to try to minimize, decrease, and cut off the spread of H5N1 across poultry in New York City and the surrounding counties. So that coordination and collaboration was very useful, because our role in the New York City Health Department was to actually contact all of those live poultry markets to make sure we spoke with the people managing the markets and the workers, and we gave them guidance on how to monitor for symptoms in case because they were in close contact with the birds, in case they developed any symptoms, and what to do if they did. We also offered all of those workers the opportunity to get treatment with Tamiflu, even if they didn't have symptoms, as a prophylactic measure. And then we continue to work with all of those workers to make sure that their health, that they're aware of what can be done to protect their health, and that they know to call us. And we partner with health and hospitals to make sure that they can get what they need should they develop any symptoms or if they have any questions. So again, our role in the New York City Health Department is really protecting the humans, the people, the workers, and making sure that the public has the information they need to protect themselves. But again, no person-to-person spread is the most important message.
Okay, now I'm going to ask about Mpox. Press reports last week detailed a new strain of Mpox present in New York City, with the CDC reporting that an individual with this new strain was in isolation, with federal websites providing Mpox guidance currently down due to the president's executive orders. What guidance or resources does DOHMH currently have available for New Yorkers seeking medically accurate info on Mpox?
Thank you for that question. Mpox has been in the news more recently because there is an ongoing outbreak of Mpox in Central Africa of a different clade 1. And there was recently, as you mentioned, a case of clade 1 Mpox in New York State. It was not in New York City. And that person had a very recent history of travel to the region in Africa where there is an ongoing outbreak of clade 1 Mpox. So I just want to reassure the public that that is really not a general public risk. The reason that person unfortunately acquired that clade of Mpox was because of the recent travel. However, the New York City Health Department has been leading New York City's response to Mpox since 2022. Every year, and routinely, we monitor all of the cases of Mpox in the city. We also issue guidance to New Yorkers on how to protect themselves from getting infected with Mpox. All of that guidance is available on our website. And so I would encourage the public to check out our website, which has extensive information about Mpox at nyc.gov/health. On that website, you will also find information about the risk factors for infection with Mpox, and the public will also find information on where they can get vaccinated at low or no cost for the Mpox vaccine as well. All of that information is still available, but again, we are not expecting further spread of that clade 1 type of Mpox because it was directly related to recent travel. I would like to invite my colleague, Dr. Reddy, to share a little bit more about how we track Mpox cases.
Sorry. Hi. Thank you, Dr. Morris. Yes, we track Mpox cases. So we receive reports. All positive cases of Mpox are reported to the health department, and when they get reported, we have teams of investigation staff who contact all reported cases and interview patients and ask them about their possible risk factors, and also perform any contact tracing and offer vaccine to contacts as well.
So I have a question. There are individuals who, when we had the Mpox scare, got, because you have to get 2 shots, right? 2 vaccines. They only did it once. Should they do it the second time just for purposes of being prepared? And so if you can go into that a little bit, we'll do this little public service announcement.
Absolutely. Absolutely. The most effective dose is to have 2 doses of the vaccine. Each person is in a little bit of a different situation. So it depends a little bit on their risk factors, the state of their immune system, et cetera. So my guidance would be talk to your provider. It depends a little bit on how recently you got the first dose. You may have to start over. It really does depend on each individual situation. But our strong guidance is to get 2 doses to be the most protected as possible from the Mpox virus.
So when will I'm going to go into tuberculosis now. When will the 2024 Bureau of Tuberculosis Control annual summary be published?
Thanks for that question. Yes, we will be publishing the annual report around the time of World TB Day, which is end of March.
Okay. And you'll share that with us?
Absolutely.
With the council? Okay. What is DOH-MH's current policy regarding tuberculosis and for containing the spread of tuberculosis, and how does the recent outbreak in Kansas impact this work?
Well, I will say, interestingly, as a physician, tuberculosis is one of the diseases that we often struggle with because it grows slowly, it can be hard to diagnose, and it's one of those things that can mimic a lot of other diseases, so sometimes it can take a while to get the diagnosis. However, the New York City Health Department has a long history of successfully responding to tuberculosis. We have seen an increase in tuberculosis cases. Our 2023 report did show that cases were up, and again, we'll be releasing our newest data in March of this year. We have a number of different policies and programs that are focused on diagnosing tuberculosis and getting people into treatment immediately. And we offer that treatment at low or no cost to anyone in New York City, regardless of documentation status and regardless of insurance status, at our tuberculosis clinics across New York City. So we offer contact tracing as well. The contact tracing is important to make sure we understand who might have been exposed if someone does develop active tuberculosis. And again, we work with our partners at Health and Hospitals and many hospitals across the city to make sure that anyone who is diagnosed with tuberculosis gets started on treatment as quickly as possible and has a case manager who actually helps to make sure that they take their medications every day. All of that data, of course, is part of our extensive surveillance system across New York City, and that allows us to create the annual reports, but it also guides our programmatic activities to make sure we get the rates of tuberculosis lower.
In the 2023 Bureau of Tuberculosis Control Annual Survey, DOHMH noted a 28% increase in TB cases from 2022 and 2023. How are you responding to this increase?
Thank you for that question. We are very concerned about the increase in tuberculosis cases. The things that we've done to respond, number one, we are doing our best to hire more case managers. We want to make sure that every case manager has a reasonable number of tuberculosis patients so that they can ensure that they're cared for, that they get the treatment they need, and that they're supported to complete their treatment, which can be 6 to 9 months or longer, depending on the type of tuberculosis they have. So we have ramped up our hiring activities to make sure that we have enough case managers and contact tracers to make sure that we can trace anywhere that tuberculosis is happening and get people treated. I would also ask my colleague Suda Reddy to share a little bit more about our tuberculosis program.
Actually, I work in the Bureau of Communicable Disease, and TB is managed by a different bureau, but yes, all cases that get reported get investigated, and there's a case manager that does contact tracing and follows up with cases and contacts to make sure that they're following their treatment plan.
So one of the things I want to ask about is in the survey, there was a talk about a strain that was resistant to the drug rifampin. It doubled from 2022 to 2023. So what are you doing about that, and what's the level of threat to the city around that strain?
Part of our surveillance system is to monitor and make sure we know if this is a routine kind of tuberculosis strain or a drug-resistant strain. Over time, there has been more and more drug resistance, unfortunately, for tuberculosis. However, we do have treatment regimens that for even patients who have evidence of drug resistance, there are regimens that are still effectively able to completely treat their tuberculosis. Unfortunately, it's just usually a longer treatment and more medications. So the appropriate response, which our colleagues in the tuberculosis program are doing, is making sure that those people who do have a strain of tuberculosis that has some resistance are on a regimen that is still going to cure them of tuberculosis, and that they have the support they need to tolerate the number of medications and the length of treatment that they need because of that resistance.
Okay, Ebola. A suspected Ebola exposure at a Manhattan urgent care facility had 2 patients rushed to the hospital by emergency workers on Sunday. First responders equipped with personal protective gear treated and transported 2 individuals to Bellevue Hospital for further evaluation. After the FDNY consulted with DOHMH, officials determined that neither patient had the Ebola virus. Describe the process in place that led to the determination that these individuals do not have Ebola, and what steps DOHMH takes when this type of general situation occurs.
Thank you for the question. I really want to start by saying how important it is for our colleagues in the media to verify before they publish information about things as concerning as Ebola, but really about all public health threats. Unfortunately, there was a lot of confusing and inaccurate information about this particular incident that was spreading in social media and on the news that had not been verified. So it was very difficult for us to get hold of the situation and really get accurate information out there as quickly as possible. So again, that's just a request to our colleagues in the media to really be rigorous about confirming information before publishing. The second thing that I'll say is we are very lucky in the New York City Health Department to have infection doctors on call 24/7 365 days of the year. And so those physicians and clinicians in the New York City Health Department, they respond any time of day, 2 a.m., 2 p.m., no matter what time it is, when there is a public health threat. In this particular case, the on-call physician from the health department was called. They did an extensive series of interviews and questions with the people who are at the center of this particular issue. They had symptoms, unfortunately, of a GI illness, but they actually had no exposures to Ebola. And that was the most important thing. It takes detailed expert questioning to determine if someone has an exposure or an actual risk of being exposed to something like Ebola. And that can be determined with a very detailed history based on that person's travel, not just the country they went to, but what did they do while they were in that country? Where were they working? Were they exposed? What types of activities did they do? That's what helps us to determine if there's any risk. And I want to be very clear, there was no exposures and no risk for Ebola for the two people in question. I wish that their privacy had been protected and maintained more. And I also just, again, request that information be verified before it's published. So to be very, very clear, there were no exposures to Ebola that we're at all in New York City. And it was a reminder of how important it is for us to coordinate with FDNY, with NYSEM, with Health and Hospitals, and with all of our colleagues and sister agencies who are part of the team that responds to public health threats and public health emergencies. But again, there was no exposure to Ebola and no evidence that there is any case of Ebola in New York City.
Okay, two things. One is I want to acknowledge that we were joined earlier by Councilmember Mealy. I have a number of other questions, but I want to hand it over to my colleague, Chair Moya, to ask questions, and then I'll circle back. Thank you.
Thank you, Chair Schulman. Commissioner, good morning.
Good morning.
I just want to talk a little bit more about the infectious disease monitoring and testing. I know you spoke a little bit about this earlier, but what is DOHMH's role in detecting and monitoring infectious diseases? And is this monitoring restricted to the city, or do you monitor worldwide?
Thank you for that phenomenal question. I'm actually going to ask my colleague Suda Reddy to describe the very complex and extensive process we use.
Hi, thank you very much. We have a really robust surveillance system at the health department where there are over 100 infectious diseases that are required to be reported to the health department. Most of our reports are actually received electronically, but all healthcare providers and laboratories are required to report those infectious diseases to us. Some of those diseases that are of high consequence, like Ebola, for example, are required to be reported immediately by phone, even if it's a suspected case. But for many of our other pathogens, they're required to be reported to us within 24 hours. So we really have a great, robust surveillance system for infectious diseases in that respect. We also have other systems like syndromic surveillance. So from all of our hospitals in New York City, all the emergency departments, we have 100% participation. We get chief complaints reported to us every day. And we look at that data to identify possible increases in infectious disease syndromes. So that's kind of basically what we have in New York City. And as Dr. Morris has pointed out, we have really strong partnerships with other health departments in the region and across the nation. And so we hear about possible clusters and outbreaks that are happening in other jurisdictions, which can give us a clue that there could be something potentially in New York City. And so it can give us a little heads up that, something that we should be on the lookout for if we don't already have it here.
So that was my follow-up question was, because these surveillance systems that you have in place and working with other agencies and that, does that help you assess whether the outbreak in another state or country presents a special risk to New York City?
Yeah, yes, thank you for your question. So One example I will go to is a possible foodborne disease outbreak. So last year we investigated in the U.S. there was a large outbreak of listeriosis associated with deli meat. We had cases here in New York City, and there were cases in other states. And so because we have this surveillance system of reporting cases to the health department, but also sending specimens to our public health lab, we're able to do additional testing on specimens or isolates to see that patients that were diagnosed with listeria that was related to deli meat in New York City were related to had the same strain in other states. And we have systems in place of data sharing, both on the risk factor and epidemiologic level, but also on the laboratory level to see that patients with the same strains in New York City were similar to those in other cases. And we have such a great data sharing network that we're able to compare data on what people ate to help us identify the deli meat as soon as possible.
Thank you. And what federal support or information does the agency rely on in its disease monitoring work? And what about the WHO support or any other international support that you may get?
Should I take that question? Okay.
Thank you for that question. And I just want to, SUDA is very humble, but New York City is the place, of course, that is like the portal to the rest of the world. So we have the most expert investigators and leaders in our Bureau of Communicable Disease and across our infectious disease division, because this is the place where things often show up first, and we have so many risks in New York City because of being such a global city. So that's why it's all the more important for us to have experts like Dr. Reddy and experts like we have across the agency to know immediately and be really prepared to have those surveillance systems kick into action if and when there are concerning threats. I do want to answer your question about what federal supports actually allow that to be possible. Our federal funding is about $600 million. That $600 million does fund our public health lab. It funds our surveillance systems that Dr. Reddy just shared. It funds our HIV programs. It funds a number of our core public health activities, our vaccination programs. We do expect the federal government to uphold their contracts and agreements with us to continue that work. But should that change, we of course are planning to work both with City Hall, OMB, and you all at City Council to make sure that our activities can continue to protect the health of New Yorkers. But again, our expectation is that our colleagues at the federal government will uphold the existing agreements and that $600 million in funding will continue to make sure that some of our most core public health activities continue. The final thing I'll say is that about 80% of our funding in our disease control division is federal funding. And that is the division where SUDA works. That's the division that does a lot of our surveillance for infectious diseases, our tuberculosis programs, our HIV programs, our vaccination programs, et cetera.
Got it. Thank you. And as you had mentioned, New York City is the international hotspot, and we receive visitors from all over the world every day. Is the city currently working, and from other states as well, is the city currently working, is currently requiring people who come from outbreak hotspots to test for diseases like the measles and TB, as reported, as reports have detailed, that are currently impacting places like Kansas City and Gaines County, Texas? Is there anything that the city is requiring at all?
There are robust systems to monitor anyone who's coming to New York City to live for those kinds of things. Those systems vary by the type of and category of person who's coming. It depends on, the reasons that they're coming to New York City and a number of other things. I would also say that for anyone who's presenting to our hospitals and presenting to our healthcare system, there's also a number of different ways that we can surveil and monitor and make sure that they have all the health supports that they need. But I think you're probably referring a little bit more to during COVID, for example, there was a requirement for travel to be tested for COVID. That's kind of in the middle of a public health emergency. That's a particular kind of intervention we might use. And otherwise, that it really does vary person to person. I do want to also underline, however, for anyone immigrating to the United States, there is routine testing for tuberculosis, for vaccination, for a number of other requirements for immigration. So that is also a part of the system.
Okay. Thank you. And I want to switch over to the wastewater surveillance. Can you describe what the current wastewater collection and sample testing protocols are, and is the wastewater testing for COVID-19 still occurring, and what other infectious diseases are you currently monitoring for testing?
Absolutely. I'll pass that one to my colleague, Sudha Reddy.
Hi, thank you for the question. Yes, so for wastewater surveillance, we do collect samples every week from multiple sources. We collaborate with our colleagues in the Department of Environmental Protection. Those samples, we do still test for SARS-CoV-2. We also test for influenza A and B, poliovirus, and I think that's it.
Got it. And are you coordinating with the federal government to detect and test with the reports on New York City's wastewater as well?
Yes, currently we do coordinate with the New York State Health Department and also with the federal government.
Talked a little bit about bird flu before. Just a quick question on that. Is the bird flu detectable through the wastewater testing, and is testing being used to monitor that current outbreak?
We are planning to test for H5. The strain is H5N1. So there is a plan to test for H5, but it's not up and running yet.
Okay, but it is coming.
That is the plan.
Okay, great, thank you. When it comes to vaccination guidance, I wanted to talk about sort of the changes to COVID-19, the flu, RSV vaccination guidances. New York City has currently experienced the worst flu season since 2020. What is the department doing to prevent hospitalization and protect our most vulnerable New Yorkers who are unable to get vaccinations for respiratory illness due to age or medical reasons?
So this has been a very heavy flu-dominated respiratory viral season. I do want to share, however, our most recent data showed that the number of flu cases we had in the most recent week was 16% lower than the prior week. So we are starting to see a trend. We're hoping that we're past the curve, but that doesn't negate the fact that it has been a very flu-dominant respiratory viral season. All of that said, I myself practice at Kings County Hospital as a hospitalist and internal medicine doctor and see lots of patients, unfortunately, who are hospitalized with the flu. There are very few people who are not eligible for the flu vaccine. And so our main focus at the New York City Health Department to protect New Yorkers is to encourage everyone who's eligible, which is most people, to get the flu vaccine. And that vaccine is particularly important because it actually decreases the chances of the need for hospitalization or death if you are infected with the flu. So one of the best ways to prevent hospitalization, to decrease the number of people in the hospital that I see every time I'm at Kings County with the flu, is to get that vaccine. We also encourage all the other tried and true, evidence-based, effective public health interventions. That includes things that are more routine, like if you're sick, stay at home, get tested if you're sick, because you want to know if you have flu, you might be eligible for treatment. You want to know if you have COVID, you might be eligible for treatment. Those treatments can keep you out of the hospital. The other thing we encourage everyone to do is hand hygiene. And then we also encourage everyone to consider wearing a tight-fitting mask if they're in crowded public spaces. And certainly if you're sick and you have to leave the house, wear a mask. So those are the things that help us flatten the curve. They're the most evidence-based interventions. They work. And so we encourage more and more New Yorkers to follow that guidance and also get the flu vaccine. In fact, it's not too late. You can get your flu vaccine now.
Great, thank you. And we touched upon this earlier. Considering the documented record of vaccine misinformation from the new HHS secretary, how is the department working to prepare any potential changes to existing vaccine guidance for illnesses such as COVID-19, the flu, RSV?
Thank you for that question. We have been doing planning around lots of different scenarios with potential changes in federal guidance. We, again, will coordinate very closely with the state health department. And what I can promise council is that we will continue to use science and data and evidence-based recommendations to continue, recommendations for vaccination for New Yorkers. Those things and that reliance on science and data will not change. Even if there are changes in federal guidance, again, we will use our expertise within the health department and the data that we know is effective to make sure that New Yorkers have recommendations that are reliable and that will protect them. The other thing that I will say is that federal guidance is it's guidance. We still control the Board of Health here in New York City. The Board of Health is one of the levers that we use to set evidence-based guidance and recommendations as well. And again, we partner with hospitals and other institutions across the city to make sure that the guidance that we issue is reliable and effective. We do the same with the state. So although I can't predict the future, I can guarantee council that we will continue to follow evidence-based and science-based practices around vaccination.
Great, thank you. And sticking to that, the potential changes to childhood vaccination guidance, right? What is, if you can describe like what the current work on childhood vaccination and immunization schedules are in New York City, and how do you plan to respond to any changes to the childhood vaccination guidance and immunization schedule at the federal level?
Thank you for that question. I am aware that the new HHS secretary has stated that he's going to be re-examining the childhood vaccination schedule. Again, I would encourage any re-examination to be done with experts in the field who are the standard setters, as well as the institutions like the American Academy of Pediatricians that have been the standard setters and the, let's say, evidence-based North Star for vaccination for decades. If there are changes in the federal guidance, again, that is guidance. We would still, here in New York City, be able to continue to issue recommendations based on our determination, use the Board of Health when we need it. I think my big concern, and one concern that keeps me up at night, is that our federal funding could be contingent on adhering to a new childhood vaccination schedule that we potentially disagree with. So if that scenario were to happen, I would definitely be relying on council, OMB, and the city, as well as our partners at the state, to make sure that we can continue a program that is rigorous, science-based, and effective in protecting the health of New Yorkers. The final quick thing I want to say is even before all of these changes at the federal level, we were seeing decreases in the rate of childhood vaccination in New York City. I am concerned about the risks of a measles outbreak here in New York City. We had a measles outbreak in 2018, 2019, where 649 people developed measles, unfortunately. That was extremely concerning. At that time, the 2018 birth cohort had a 94% measles childhood vaccination rate at 24 months for one vaccine. Right now, our 2022 birth cohort, that vaccination rate is 84%. So that, 81%. So that is concerning that we have low rates of measles vaccination here in New York City. And certainly it is something that gives me concern and anxiety, the risk of measles vaccinations. Regardless of what happens at the federal level, we need to push New Yorkers and their families to make sure that their children are on schedule for routine childhood vaccination.
So going with that schedule, how could those changes to the childhood vaccination guidance and immunization schedule impact herd immunity in New York City in both the short-term and long-term plan, and what risks would any such changes pose to children and adults who are unable to be vaccinated due to age or medical reasons?
There are very, very, very rare exemptions for the measles vaccine, so almost no one would be exempt from the measles vaccine. What I will say is that we are concerned about the low rate of childhood vaccination and the low rate of measles vaccinations. Regardless of changes at the federal level, our work at the New York City Health Department continues. We do extensive outreach in communities across the city, including in New York City public schools, to encourage vaccination. We also do so in child care centers, et cetera. So our educational campaigns continues. In fact, our newborn home visiting programs also engage around vaccination and encourage parents to vaccinate their children. Pediatricians are the most trusted source of information for parents and kids. That's been proven over and over again. We partner very closely with pediatricians across the city to make sure they have the support they need from us, information in every language available, at every language possible, and rapidly available information to make sure that their patients are well informed about both the safety of the measles vaccine as well as the risks of a measles outbreak. So we intend for that work to continue, and we intend to continue all of our efforts in educating the public about the safety, efficacy, and importance of childhood vaccination as well as other vaccinations.
Great. Thank you so much.
Thank you.
Turn it back to Chair Schulman.
Yeah, actually, I wanted to follow up on Chair Moya's question about the measles. Have you talked to Moya about,
Not me.
not him, the MOIA, about immigrants not being fearful of coming forward for vaccines and, given everything that's going on, particularly in the schools?
Thank you for that question. We have a really close collaboration with Moya and have for many years at the New York City Health Department. And the commissioner of Moya, Commissioner Castro, has been just an incredible advocate to make sure that immigrants, regardless of documentation status, have access to all of the public services that are available to them by right. That includes health and hospitals, that includes many of the programs we run at the health department, that includes many other services as well. And there have been efforts to make sure that information is available to our newest New Yorkers and to all immigrants across New York City to know their rights about accessing care and protecting themselves. We've been a part of those efforts at the New York City Health Department as well and are very proud of them. And so our hope is that all New Yorkers will continue to seek health care and preventive care no matter what. That is our hope and our intention.
And I don't know if you do work with the New York Immigration Coalition. I assume that the commissioner does, because
Yes.
they're pretty, really good organization to work
Absolutely,
with,
yes, we
especially
do.
around some of these issues.
We do.
So I'm going to ask you just a couple of other questions, and then I'm going to hand it over to my colleagues. What is DOHMH's fiscal 2026 preliminary budget for public health emergencies?
Thank you for asking that question. I'll have to defer that one to our prelim budget hearing, which is
Okay,
on March the 24th.
that's fair enough. So I'll disperse with that. Can you provide a break? There'll be funding questions around MPOX and all of that. So what I'll ask you now is the pre-considered resolution we're hearing today calls on the New York State Assembly to pass, the New York State Senate to, the New York State Senate actually did introduce it, and the governor to sign A2705, and what's the Senate? Okay, there is a related Senate bill that was just introduced relating to the amount of state aid reimbursement for public health services by a municipality in the city of New York when the municipality is providing some or all of certain identified core public health services, otherwise known as Article 6 funding. How much funding has DOHMH lost since fiscal 2019 due to the reduced Article 6 funding? Do you have that?
Yes, our estimate, thank you for the question. Our estimate is that we're losing somewhere between $60 and $90 million per year because of the lack of an equitable and fair match. That means that New York City is paying 80% of our costs for all public health services, while surrounding counties and the whole entire rest of the state is paying about 64%. The reason that that inequity is also a problem is because of what I mentioned. New York City is the portal to the rest of the world. We have we are the most global city in the country, and so it's even more important that we have the investments in our public health surveillance services and other services to ensure the health of New Yorkers. So we are concerned about this lack of appropriate and equitable match funding for New York City. We're losing about $60 to $90 million per year, and I am very appreciative of New York State Health Department, Dr. McDonald's understanding of this issue, which he described in his budget hearing testimony just a couple of weeks ago.
Oh, that's great. If we were to get these funding, if we were to get this funding restored, what would you use it for?
Thank you for that question. We have a long list of things. Well, first and foremost, I should say that community-based organizations that we fund also lost funding because of this gap or cut in funding, I should say. And I would also say that with the restoration of the match and an additional $60 to $90 million per year, our planning would be to invest even more in our surveillance systems, in our community-based services, in our programs that are targeted towards marginalized and vulnerable communities, and make sure that our core public health services are even more shored up. And again, because of the risks that we are aware of with federal funding, we also would use those services to make sure that we don't have to cut any services if we were to start to see cuts in our federal funding. So this funding would be incredibly important for us to shore up and invest in the core public health services that we are implementing right now, particularly considering the risk of federal cuts.
So the companion Senate bill, by the way, is 4801. I want to thank Assemblywoman Jessica Gonzalez Rojas, who introduced this originally. We've been pushing, as you know, on the council level, the speaker, as well as City Hall, to get the restoration of these funds since we were all elected and took office in 2022. And I also, Senator Gustavo Rivera is the one that put in the Senate version of it, and he will be testifying at some point today. The Assemblywoman could not make it here today, but she is submitting testimony, and she's been a real champion of that. So we're thankful to her. So now I want to turn it over to my colleague, Councilmember Narcisse, to ask questions. Thank you.
Thank you.
Good morning, and thank you, Chair, both of you. And I'm not going to get to the name. So thank you so much. I want to say thank you to Dr. Morris and Dr. Gutta. I don't want to say it wrong. So thank you. You realize that you have the world on your shoulder right now when it comes to
In partnership
illness.
with you.
You have it
Not
on your
just that.
shoulder. And as my colleague mentioned, that you are doing a very nice job. So I want to say thank you for that.
Thank you.
It is a difficult time. I'm anxious for you. I have lots of anxiety by sitting here for all the questions. Being a healthcare professional, registered nurse, it hurt my heart, knowing that everything we do is about detecting, preventing, and of course, responding. How are we gonna respond to all those things, to all the diseases that are coming our way? We agree that we are a hub of the world. Everybody passed through. I can tell you my experience during COVID-19 when I was somewhere else in Europe, when coming back, and I'm saying to myself, I said, this thing's gonna hit us hard. And it sure did hit us hard. So we know the needs. And now how we can trust the federal government, like recently, about last week, they took $80 million out of New York City. And we have the state for the undocumented. When you're talking about hospital, we lost almost 56, he took 80 million, and then the state take about 56 something million for undocumented things, that services that we can provide in our hospital. That is so scary. My question to you, how we gonna provide the services for infectious diseases and continuing with the vaccines? We know the trust is not there. A lot of folks don't have no trust. And looking at the federal now, who's responsible for that? How we gonna continue building trust in our community to get people to get vaccines?
Thank you for that question. We have our work cut out for us. I agree with you. And I do agree also that since the COVID pandemic in particular, there have been a lot more concerns and questions about vaccination, unfortunately. Misinformation and disinformation is a part of the reason that trust in health professionals, doctors, public health has eroded. And so part of our charge is to make sure that all of our communities have accurate information and that the messengers for that information are people that they trust. Now, we were able to do that somewhat successfully during COVID because we made large investments. The one example I want to share is our public health corps program, which is in partnership with Health and Hospitals, where at the height of the pandemic, the COVID pandemic, we invested $100 million across 100 community-based organizations, and they focused their efforts on vaccination, information sharing, town halls, community events, giving out free masks, free test kits, walking people to vaccination sites, et cetera. And we were able to get the vaccination rate for Black and Hispanic New Yorkers up across the city, and also in the neighborhoods that had lower vaccination rates, we were able to get those vaccination rates raised. But it required a lot of work. It required us partnering with community-based organizations. It required us making big investments across government, and it required us focusing where the data tells us to focus. That is focusing in the communities that experienced unfair and disproportionate impact, to make sure that they had the resources that they deserved with the messengers, the language, and the way in which they wanted to receive that information. But that was a big victory. So this is something that we can overcome. And our expectation, of course, is that those kinds of efforts will continue in order to get our vaccination rates higher. I do want to also acknowledge, however, that just over the weekend, we learned of 7 staff who work for the CDC but were assigned to us in the New York City Health Department who were unfortunately fired. Those 7 staff are people with tremendous expertise and expertise that the health department needs. And so we're doing our best to figure out how we can retain them. But that's just now. I don't know if more layoffs from the CDC are coming, but I am worried about that.
It's scary. We have to be proactive, right? Not reactive. We're talking about $600 million to keep our infrastructure. So now we don't even know where we're at, right? Now we withdraw from the World Health Organization, which from nursing, that's all we talk about. Whenever we want a reference, that's where we go. So how you see that we gonna be able to keep it together in New York City? I'm scared.
I intend to partner with council and partner with City Hall and OMB to make sure that we're able to continue our work and continue to protect the health of New Yorkers, because that is our mission, to protect and promote the health of New Yorkers. I'm not saying it's going to be easy. It is a very challenging time. And at the same time, that is our job in the New York City Health Department. We have been doing it for 220 years, and I fully expect for us to make sure that we continue to protect New Yorkers despite what are clearly very difficult times and shifting sands. I do also want to clarify, we have not received notification of any cuts yet to our federal budget. So at this current time, we are still using and implementing the work that's related to our $600 million in federal funding, and our expectation is that the federal government will uphold the contracts and commitments that it's made to New Yorkers around those federal funds.
We can say that I read a statement right here, which I love. In other words, I'm not going to read the whole thing. We can literally buy ourselves more health and time.
That's right.
But in the most underserved population, when things like that happen, it's so scary because we know it's the underserved community that's going to get the biggest hit.
Yes.
So what's your plan?
Underserved is a choice. And, I can't make up for generations of policy choices and systemic racism in, months or weeks or even years. It's going to take time. But what I will say is that what we learned during the COVID pandemic and what commissioners prior to me have worked on is making sure that we use interventions and focus our programs in the places and communities that have experienced unfair impacts. So across the whole entire health department, we have a program called Race to Justice that's focused on making sure all 7,000 of our staff understand the ways in which policy choices, history, exclusion, et cetera, have shaped the current health outcomes that we see. We also have neighborhood health action centers in 3 neighborhoods across the city that are the neighborhoods that have the most unfair outcomes for health outcomes. And those action centers are intended to help to focus on that exact issue that you're describing. And then we're continuing to use policy tools like our Board of Health declaration of racism as a public health crisis, and partnering with the Mayor's Office of Equity and Racial Justice, Commissioner Sadia Sherman, to make sure that the citywide racial equity plan that was passed in the charter and is planned to come out at some point, that those documents really guide the remedy and the repair that needs to happen in communities that have been historically underserved.
I want to say thank you to you, but we have to continue pushing for folks in data-driven. That's what we do in science. Science is not something that you just can get up and say, this is what it is. So thank you, Doc, for the surveillance and making sure that we protect New York City. I love New York City, and I know so many of you love New York City. This is a time that you have to take care of yourself too. Self-preservation and self-wellness. I would say deep breathing, because I was here, my neck was getting tight from hearing it alone. So I know you're having a hard time, and I want to say thank you to you for the work you're doing. Thank you so much. Thank you, Chair.
Thank you, Councilmember. Councilmember Marmorato?
Thank you, Chair. So I just wanted to talk about the H5N1 flu. I have a lot of live poultry markets in my district, and I know that they were shut down. Are you aware of any financial assistance or educational assistance that the city is going to provide not only to the business owners, but to the employees who may lose wages as well?
Thank you so much for that question. In the New York City Health Department, our role really is to partner with the state health department and to support education, outreach, and any health concerns for the workers in those markets that were exposed. So we're much more focused on kind of their health than the business side. I'm not sure if my colleagues in the Small Business Services, the SBS agency, would be able to be more helpful, or the New York State Department of Agriculture and Markets may perhaps, but we do, our realm is really the health of the workers.
Okay, do you have stuff like on a website that I can have the employees look up, or?
Yes, we do. In fact, we have a H5N1 page. If you go to nyc.gov/health, you'll be able to find our H5N1 page, and it does have information for the general public. It also has information for workers in live bird markets about what they should do to protect themselves.
Great, great. And also, I just wanted to touch on the suspected Ebola exposure. I was really disappointed to see that both individuals, both patients' pictures were in the media. And I was kind of a little heartbroken by that, and I felt like there was some type of HIPAA violation happening. I do have a healthcare career of 24 years, so I know there was some kind of a disconnect there. I understand that there are multiple agencies involved. will you, the Department of Health, do an investigation to see whether or not something came from not just your end, to see how this was leaked to the media and how we can do a better job going forward?
I will I share your concern about the privacy of the two individuals involved. Again, I, as a practicing physician myself, I can't imagine, being in the middle of feeling sick and ill and then kind of having your privacy really taken away in the way that it was. So I am also very concerned. It's not really within our realm or powers to do that kind of investigation, but we do have planning activities with our partners at NYSIM, FDNY, Health and Hospitals, as well as the partners at CityMD in process to really, again, make sure that our coordination, at least within our realm on the health side, is as strong and as clear as it can be. But I don't believe it's within our realm to do that kind of investigation.
Okay. Would this have been like between you communicating with one of the other agencies? Is it like something that would have been like seen online or through some type of app? Do you think it was like leaked in that sense, or?
That is not my understanding of what happened.
Okay. All right. Thank you so much. Thank you, Chair.
Okay, thank you. Yeah, we're gonna, so do we have two members of the legislature that are gonna testify? I don't know if you want to stay for that. You don't have to. We're good.
Okay.
Thank you very much, Commissioner Morse, and we really appreciate the level of substance that you provided for us to this hearing, as well as your colleague, and we really appreciate both of you being here, and we look forward to the budget hearings that I will have as chair of the Health Committee at the end of March, because it's really important. Particularly, I just want to mention that we are going to ask questions about the individuals that were assigned to CDC from DOHMH, so, and we want to provide whatever assistance that we can. So we really appreciate you coming here today and want to thank you.
Thank you very much, Chair. Thank you. Thanks.
I now open the hearing for public testimony. I remind members of the public that it is a government proceeding and that decorum shall be observed at all times. As such, members of the public shall remain silent at all times. The witness table is reserved for people who wish to testify. No video recording or photography is allowed from the witness table. Further, members of the public may not present audio or video recordings as testimony, but may submit transcripts of such recordings to the Sergeant-at-Arms for inclusion in the hearing record. If you wish to speak at today's hearing, please fill out an appearance card with the Sergeant-at-Arms and wait to be recognized. When recognized, you will have 2 minutes to speak on today's oversight topic of detecting, preventing, and responding to public health emergencies in New York City, or on the resolutions being considered today, Resolutions 330, 401, 642, 650, 721, and 722, or the pre-considered resolution about Article 6. If you have a written statement or additional written testimony you wish to submit for the record, please provide a copy of that testimony to the Sergeant-at-Arms. You may also email written testimony to testimony@council.nyc.gov within 72 hours of this hearing. Audio and video recordings will not be accepted. Before we get to our panels, we have 2 members of the state legislature that want to testify, and so we're going to ask Senator Rivera, Gustavo Rivera, who's going to speak on Article 6, to be the first one. Senator Rivera, are you with us?
I am indeed. I'm trying to start the video. I guess if it's just audio, then it's just audio. Can you hear me, Madam Chair?
Yeah, I can hear you. We're
Okay.
trying to figure out the video, but go ahead.
Okay, thank you for giving me the opportunity to be here virtually, both to you, Madam Chair, as well as the Chair of the Subcommittee on COVID and Infectious Diseases, Councilmember Moya. This is certainly a timely conversation that we're having right now. So I'll do a couple of things as I only have 3 minutes. First of all, related to Article 6 funding, let us not remember that in 2019, it was Governor Cuomo then who changed the reimbursement rate for the city. You already heard about the results that that has on a day-to-day basis. For the last couple of years, we've been trying to reinstate that funding. And that because it leads directly to funding for health education, health insurance access, prevention, treatment, child and maternal health, you name it. And we have a bill that, as you mentioned, Assemblymember Jessica Gonzalez Rojas has a bill that I just introduced. I thank her for championing the bill. I carried in the Senate. It's 4801. So certainly I'm very supportive of that bill, and I'm thankful for a conversation today about it. And then I also wanted to speak quickly about I want to thank council members Crystal Hudson and you, Madam Chair, for introducing resolutions on two important bills of mine. The first one, we refer to it as the CDPAP Accountability Act. That is Bill 1189 in the Senate. Very briefly, this refers to a program called the Consumer Directed Personal Assistance Program that has been in place for many years in the state of New York. And last year, wait a minute, I'm getting asked to start my video, so I'm going to do it now. Hopefully you can see me now. Hello. The CDPAP program, or Consumer Directed Personal Assistance Program, started a few years ago in the state of New York, and there has been. It is true that the way that the program has been structured has allowed bad actors to come into the space and act as fiscal intermediaries, but not do so with the interest of patients or the program at hand.
Keep going.
So many of us felt that it needed to be changed. Unfortunately, a decision was made by the governor and she pushed it through in the budget last year to change it from hundreds of fiscal intermediaries to a single one. I've always believed that that was an unreasonable change, the transition, which is supposed to happen until by April 1st of this year, it does not seem like it's going well. And I have many concerns about what gaps in service might exist. So I know that there's a resolution before you in support of this bill 1189 to create a more reasonable transition time of 2 years, also create standards so that the Department of Health can crack down on bad actors. And I'm hoping that resolution becomes a reality. And the last one is related to my asthma inhaler bill, which is Senate Bill 1804, which will require coverage of asthma inhalers at no costs to folks in the Medicaid program. And this is 1 in 8 children in the Bronx, as an example, suffer from asthma, and that's due to indoor and outdoor air pollution, tobacco use, barriers to quality and affordable health care, and care to affordable health coverage and health care. But bottom line, this would actually make it so that poor and working class families would have access to something that is required for so many children to be able to lead basic quality lives. So I'm certainly thankful for this conversation overall, and thankful for the support for all these pieces of legislation, and for your continued work to make sure that the city of New York is healthy. So thank you, Madam
Thank
Chair.
you, Senator. And if there's anything that we can do to help with some of these pieces of legislation on your, please let us know. If there's a letter we need to write to the governor or something like that, let's talk
Yes.
about that offline. Okay.
Yes, ma'am.
Thank you. So we're going to do in-person testimony. We're waiting for Senator Comrie to come up online. Let's see. Jose Hernandez. Sasha Guillaume. Sorry if I'm not pronouncing correctly. Bakari Sauer. Anastasia Somoza. Who's going first? Okay, Jose, go ahead. You have, so I just want to tell folks, you have 2 minutes, but, we'll give you time to summarize, and also you can submit whatever you didn't
I
get to
submitted
discuss.
already.
Okay, great. Go ahead, Jose.
Hello, my name is Jose Hernandez, and I would like to thank the City Council for your leadership and the opportunity to speak today. I am here to express my support for Resolution 642, and I want to thank the City Council for recognizing the importance of Senator Rivera's legislation in protecting the disabled and older New Yorkers who rely on CDPAP services. Last year, in a deal orchestrated by 1199, the governor, and possibly PPL, the Consumer-Directed Personal Assistance Program, the program that hundreds of thousands of disabled and older New Yorkers rely on, was sold to the highest bidder, which was PPL, a company with a horrible reputation in other states. The RFP seemed tailored for PPL to win and disrupt care as they have done in other states. Many of us were concerned about the transition, and that transition has started, and many of us are terrified of what our future holds. For some of us, it may mean nothing. However, for many of us, the reality is that we are going to lose our trusted PAs, the people who kept us safe during the pandemic and continue to keep us healthy and living in the community. The Department of Health and the governor, and PPL have continued to claim that everyone will be covered. However, the transition process is extremely flawed. I have known this because I have the opportunity to speak to others who have started the process and have experienced complications, which are terrifying to me. For many disabled and older New Yorkers, the process is going to be extremely difficult, if not impossible. They will have to make difficult decisions, either go without care or face institutionalization, a fate many of us consider worse than death.
You could go ahead, finish.
Imagine being disabled all of your life or becoming disabled and able to successfully live independently in the community because of CDPAP, only to have organizations like 1199, the Department of Health, and elected officials like the governor disrupt our lives. They only see numbers and not people. For that reason, I want to thank the City Council and Senator Rivera personally, because you have always seen the disabled and older New Yorkers as human beings with lives, not just numbers. I could continue to talk about this at length, but I want to just thank you all.
Thank you, Jose. We really appreciate your testimony.
Yeah. Bakari.
Hello, everyone. My name is Bakari Sawo. Thank you for giving me the opportunity to testify today. I'm the personal assistant for Jose Hernandez, and I started working for him during the pandemic. I am here to support the Resolution 642. This will help preserve the care that consumers are currently receiving and allow me to continue providing the care Jose needs to live healthily and independently in the community. My current physical intermediary pays me enough to cover my rent and provide food for my family. However, if I were to transition to PPL, I would lose income on the date of enrollment. I enjoy my job, and I care about my consumer. We have worked together for the past 4.5 years, but PPL is making it difficult for me to continue providing care for Jose. If I have to take a pay cut, I will have to decide whether to stay in this industry or seek other employment to ensure I can continue paying my rent, bills, providing food for my family. Although I want to continue working for Jose, I also have a family to support. PPL does not have a reliable history of paying their workers on time. If this were to happen to me, I would risk not being able to feed my family or possibly become homeless. My landlord will not allow me to stay without paying rent, and the supermarket will not let me purchase food on the promise that PPL will eventually pay me. Thousands of PAs like myself will have to decide between staying with their consumers or protecting their families, and PPL will be the deciding factor. Please pause transition and please pause the transition and support the resolution 642 so that companies like the one I currently work for can allow me to continue caring for my consumer while also providing a home and food for my family. Thank you for
Thank you. Before Anastasia goes, I want to mention that Anastasia Somoza is a former member of the staff of the City Council, and I worked with her when she worked here, and we worked on the CDPAP issue together. And I was a very big proponent then. I'm a big proponent now. Go ahead, Anastasia. Now I'm giving you opening. Go.
Thank you, Chair Schulman, and it's so great to see you. It's great to be back. I'm here to express my urgent and enthusiastic support for Resolution 642. Thank you to the Council and the Health Committee for recognizing the importance of Senator Rivera's legislation to protect disabled and older New Yorkers who rely on CDPAP for our services. There's a lot that I can say. Jose touched on it, so I'm going to focus on one of my more important points and then submit a longer testimony. But according to Governor Hochul and the New York State Department of Health, one of the biggest reasons why us CDPAP users were forced to move, or are being forced, currently it's already started, to move to PPL is to quote unquote save the state money. But as Senator Gustavo Rivera started alluding to, we've already seen that this saving of money is not actually taking place because PPL is already asking for advancements to meet their payroll requirements, and the transition has just begun. They're also asking for higher reimbursement rates than any of the reimbursement rates that the current FIs require. And there are also a lot of folks with disabilities and older New Yorkers who are going back to home health aid services, the typical services. I imagine one of the many reasons why that's happening is because the shift to PPL is going to put much more of the administrative responsibility on the person with a disability. And with every 1,500 disabled or older New Yorkers that switch back to HHA services, it's going to cost the state $4.5 million. So there are already trends showing, again, that this is not going to save the state the money that the governor hoped it would, and instead it's putting undue onus on disabled New Yorkers, taking away our choice, because that's the number one reason why a lot of us use CDPAP, so that we have choice, and it's making us less safe. As you heard from Jose's worker, he has to potentially choose between his family and providing Jose, who he clearly cares about, with trusted care. We don't deserve to potentially go without care, nor do our friends and workers deserve to go without the income that they need to support their families in order to provide a service in a system that's not broken. We believe it needs to be regulated, but we believe that what Senator Gustavo Rivera is proposing and what this resolution supports is a much more measured approach to the regulation that needs to occur.
Thank you very much, Anastasia. Next.
Hello, my name is Sasha Guillaume, owner of Principal Home Care. It is an honor to present before the City Council and also along with my colleagues who've been working to advocate against the single FI. Also honored to present or share the stage virtual with the orator, Senator Gustavo Rivera. I can give a speech, he can move the crowd, and I am hopeful that Senator Rivera will move your colleagues to support your bill, which will lead to necessary reforms to preserve New York agencies so that we can continue to provide service for us New Yorkers and by us New Yorkers instead of giving away the industry to an out-of-town or out-of-state company. We welcome the support of the City Council to help us send a strong message to the governor to get this right, because a single FI transition, this eminent domain of sorts, will cause many businesses, business owners to lose everything. Small business owners, some from underrepresented groups where traditional financing are not available, or those who have taken out a line of credit on their homes to finance their businesses are now facing the possibility of losing everything. Our origin story starts from my immigrant mother, a former caregiver who dared to think that she can stake a claim in the American dream by starting a business in New York City, no less. Sometimes being naive enough to think that you can is what is needed for you to try and succeed. So when our patients started inquiring about CDPAP, we created Principal Home Care to enable them to access this program. CDPAP works. For patients who are self-directing and with a little bit of help, they can be more independent. As the program evolved to allow a broader—
You can finish, go ahead.
Thank you. As the program evolved to allow a broader application, we saw patients who previously were not able to receive care due to language and other limitations be able to access care. Historically, people who look like us have been the ones providing care, and that has always been acceptable. And to meet the Department of Health's value-based goals, it is sometimes beneficial for the improved healthcare outcomes of patients and the caregivers, and that the caregivers share a common language and sometimes some cultural competencies with the patient. But I just don't think it should stop at the caregiver. I think there is value in having the owners look like the patients that we care for and not just the caregiver. I think there is value in that. And if this law is enacted, the company selected will not look like the members of all the communities that we care for. So help us send a message to Governor Hochul to move New York forward and not to go back. The governor claims to be an ally. Well, now is the time to show it. So let's repeal this law and do what's right for all New Yorkers. Let's repeal this law and return patient choice to the consumers. Let's repeal this law and empower New Yorkers to create businesses and invest in their communities. Let's support the stability and oversight in consumer-directed care bills A 2735, sponsored by Assemblymember Sturpey, and S 1189, sponsored by Senator Rivera. Let's repeal this disastrous law and save the New York's home care industry.
Thank you very much. I want to thank the panel for your testimony. It's very important to us, and if you want to submit extended testimony as well, you can do that. Thank you. So now I'm going to add. Oh.
What's the link or the website we submitted at again?
You can submit testimony to testimony@council.nyc.gov. Okay. Now we have Senator Leroy Comrie. Senator?
Yes, good afternoon. Good afternoon.
Good afternoon.
Chair Shulman and council members, thank you for allowing me to speak on this issue. The CDPAP issue that has been set up by the governor is is going to be a disaster. We had a hearing recently of the Health Committee. All of the advocates pointed out that there's no way the Department of Health can meet their goals to even register all of the people that need the help. But even more importantly, the program that is going to try to be run by one individual entity, which has a spotty record at best of delivery in other areas, makes it important for people to understand that we need to make sure that we diversify CDPAP. CDPAP has been unique to our community. There are CDPAPs that deal with deaf communities, deal with handicapped communities, deal with the different ethnicities around the state in a specific and focused way. We are going to lose a lot of small entrepreneurs who were nurses, who were small entrepreneurs that started businesses that have great records, that are going to lose their business, and we're going to affect small and minority businesses all around the state. It's going to be a disaster also for patients, because now they have to, almost like they do with Medicare and Social Security, wait an hour and a half to get online or get a phone call returned or get anything done. This is a program that was a disaster because the state implemented it poorly. Did not put enough resources in. And now they're trying to even limit your resources more by going to one entity, which is a national entity, which won't have the capacity to fill the needs for New Yorkers. New Yorkers are used to prompt service. They're used to service that meets their ethnicity needs and would understand their specifics. And the CDPAP program, as designed by the state, is going to be a failure. So I would appeal to the city council members. I want to thank Speaker Adams for allowing this hearing to be held. I want to thank Councilmember Shulman and the other council members that are putting this hearing together. And I would appeal to all New Yorkers to petition the governor to stop the CDPAP program as proposed. Thank you.
Thank you very much, Senator. Really appreciate your testimony.
Thank you.
All right, so now we're going to go to in-person, Elizabeth Polanco, Justine Tetton, and Arshelle Brooks Harris.
Question. She's going to testify in Spanish. Can I translate for her?
One second, we're finding it.
¿Está bien que el de la interpretación para usted? ¿Sí? Okay. Yeah, she's okay. Yeah, está bien.
Yes, the answer is yes.
Cuando quiera puede empezar. Ya. Gracias.
Aquí. Ok. Muy buenas tardes. Mi nombre es Elizabeth Polanco. Trabajo con el programa de CDPAT, cuidando a mi suegra. Este programa me ha dado la oportunidad de trabajar, de tener un ingreso, pero a la vez de poder darle los cuidados a un familiar que lo necesita, que está en serias dificultades.
Hello, my name is Elizabeth Polanco. Oh, thank you. Hello, my name is Elizabeth Polanco. I work with CDPAP program, taking care of my mother-in-law, and it has given me the opportunity to take care of a family member.
Con este programa hemos podido, además de cuidar el familiar, también tengo la oportunidad de recibir un ingreso y poder cubrir algunas de mis necesidades básicas realmente.
With this program, I've been not only have been able to take care of my family member, but I've been able to make a living to cover the basic cost.
Okay. Pero ahora estoy muy preocupada tanto por los trabajadores como los consumidores, porque el programa va a pasar a otra organización, PPL, y tenemos muy poca información, no tengo un proceso de transición de demasiadas personas que están ofreciendo este servicio, tanto trabajadores como consumidores, y la información que tenemos es muy mínima, siento mucha frustración. También tenemos información de otros estados que han dado demanda. Oh, sorry about.
She's also frustrated that she hasn't gotten enough information from PPL, and there's other information from other states that is, frustrating to her.
Yeah. Gracias.
Okay, ¿puedo seguir?
Pero ya tenemos que acabar.
Ah,
Entonces,
thank you.
Yeah.
Thank you.
Gracias.
Thank you. Gracias, gracias.
Hi. Good afternoon, Chair Shulman and esteemed members of the Committee on Health. My name is Justine Tete, and I'm the Director of Policy and Advocacy at Lenox Hill Neighborhood House. Thank you so much for holding this important health oversight hearing. I'm here today to represent my colleagues, our clients, and communities served by Lenox Hill Neighborhood House. Lenox Hill Neighborhood House was originally founded in 1894 as a free kindergarten for immigrants and is among the oldest settlement houses in the nation. At its core, the work has not changed since our founding. We still educate children, feed hungry neighbors, care for the elderly, advocate for vulnerable individuals, and provide critical, comprehensive services to communities in need, helping them to gain the skills to strengthen themselves today and build a better community for tomorrow. As a licensed mental health counselor who has worked with vulnerable communities, it is an honor to advocate for our underserved community members and shed light on how our city can improve emergency preparedness, prevention, and response protocols. More than our advocacy, our underserved community members need information, safeguards, and representation from our city agencies and elected officials that ease financial and social instability before, during, and after disasters, public health emergencies. Lenox Hill Neighborhood House provides essential services to over 15,000 New Yorkers in need annually, including emergency responses and preparedness. Our two older adult centers, which serve over 5,000 older adult New Yorkers annually, serve as cooling centers during heat emergencies 7 days a week. In addition to providing 3 nutritious farm-to-table congregate meals, our members also have access to a daily calendar of social activities and programming and comprehensive on-site social service support, which includes benefit assistance, access to health care, referrals, transportation, case assistance, and mental health support. Our women's mental health shelter at the Park Avenue Armory, which operates 24/7, 365 days a year, provides emergency shelter to 80 women living with mental illnesses daily and responds to both Code Red and Code Blue weather emergencies. Each year, we support 200 plus women experiencing homelessness. We have fostered safe spaces for community members with limited resources and respond to emergency needs across our programs and services for children and families to older adults. Just as the Neighborhood House has worked on providing safe spaces for the community, we urge the city to reevaluate their public health preparedness, especially in light of our new federal administration. The COVID-19 pandemic was unprecedented and unpredicted. However, quickly and significantly rippled through our city, uprooted our community's healthcare system, social service, resource reserves, and workforce. And as we move forward in rebuilding our city after a tumultuous 5 years, it is imperative that our local government recognizes the need to strengthen agency coordination, communication, and emergency response procedures. It is our job as a community advocates to be a voice for vulnerable New Yorkers. Emergency response is more than—
Can you just summarize? Thank you.
While we recognize that the investments in improving these systems will not be immediate, we remain hopeful that more recognition on these issues will spark movement to find a solution.
Thank you, and you can always submit extended testimony. Okay, great.
Thank you.
Next, thank you.
Yes, excuse my voice. First of all, I'd like to thank God for giving me this opportunity to speak on this issue that is near and dear to me. My name is Arshelle Brooks Harris. I'm the Secretary of the Board of Directors for the National Blood Clot Alliance. I got involved with the National Blood Clot Alliance after my daughter, Lachelle Brooks, passed away from a blood clot that she had inflicted in her ankle from a broken ankle at 32 years old. She left behind a 12-year-old daughter at the time. Will be year 5 in September. My life will never be the same. I thought when I lost my leg due to necrotizing fasciitis, which is a flesh-eating virus. But 4 years later, I lost my firstborn daughter due to this cunning disease. The National Blood Clot Alliance holds meetings on Capitol Hill. This will be our 3rd year, coming up on March 25th. And I've been fighting to have a resolution for New York City and for the stomping grounds that my daughter grew up with in Brooklyn, New York, and Fort Greene area with Crystal Hudson, to bring awareness of blood clots to the forefront of the communities and the surrounding communities of Brooklyn, New York, and abroad. Sorry. Losing a child, you expect your child to bury you, not you bury your child. I'm just fighting to bring awareness to people so that they can know the severity of this, and it's preventable. That's the thing about it. It is totally preventable to, get the education and learn about the signs and symptoms of blood clots so that this doesn't happen to anyone else. And I'm going to keep fighting. I've been fighting for almost 5 years for this, and I'm an amputee. I take care of my 87-year-old mom, but I'm going to keep fighting. Thank you.
Thank you very much. I want to thank this panel, and thank you for translating for us. I really appreciate it. And thank you. We have Sharon Brown and Christopher Leon Johnson. I don't know if he's here. Okay. If there's anyone else who wishes to testify, please see the sergeant and fill out an appearance card. Thank you. Sharon, go ahead.
Hello, everyone. Just before I go, remember Israel, defend Israel, release the hostages, let Yahweh's people go. Okay. The health system needs to be revamped. It is not beneficial to the people that are using it, but it is very costly. Many of the people that use the healthcare system in total, all the different aspects, they get worse, they decline. There was newspaper that reported that people were diagnosed with fatal illnesses above 50% of the time, and it was incorrect. There's a lot of things going on in the healthcare system. We need to temper it with the Bible. We're going to be putting the Bible and everything back in schools and things like that, prayer and everything like that. The healthcare system has known for a long time that prayer and going to church and things like that helps the mind, helps the body, helps you physically, different things like that. So we're going to make sure that we put those things back in schools. You guys can help us do that. The way someone thinks, that would be from the Bible. It is very connected. There are specifics on how to think, how to treat disease. There are actually plants and different things that are used in healing. And we use medications and things like that that are made with some of the same kinds of things that are in the Bible that actually cure and help these diseases, but they are not allowed in. We need the holistic medications that are from the Bible that were used from millennia that worked, and not just the things that are profitable. We need to make sure that we
Just summarize.
Yes. So we need to make sure that we go after Big Pharma and the WHO organization. I have sued the WHO organization in court because they're ineffective and they're detrimental to our healthcare system.
Thank you. Thank you.
Yes.
Mr. Johnson.
Hey, hello.
Good to see you.
Hey, what's up? Hey, Chair Shulman and Chair Moya. My name is Christopher Leon Johnson. Oh my God, like I just got the news today from the New York Post that congestion pricing is dead. Like, shout out to everybody out there that said no in the city council to support a resolution for congestion pricing. Shout out to the Common Sense Caucus. Shout out to Joan Ariola, Bob Holden, Chris Banks. Chris Banks was against congestion pricing. Shout out to everybody out there that was fighting against this health issue of congestion pricing. Congestion pricing was a health issue. It was going to hurt people in the Bronx. It was going to hurt people in the South Bronx, mostly because all the cars was going up there. I know this is the health committee and congestion pricing is not on the thing, but since it's about asthma, congestion pricing, it was going to hurt people in the Bronx because the asthma rates in the Bronx was high. And I'm gonna give a big middle finger to Jessica Gonzalez Rojas, Assembly member Jessica Gonzalez Rojas, the cokehead Assembly member Jessica Gonzalez Rojas, a big fuck you to vote JGR because
we have the quorum.
I understand. Because you said that congestion pricing will benefit the people in the Bronx, and I will never forget that. Jessica Gonzalez Rojas, and I will never forgive you for saying that on Twitter, saying that congestion pricing will benefit people in the Bronx. I'm gonna make this clear right now. Myself will never forget to the council members and the state assembly members and the state senators and all the clowns and Writers Alliance and Transall that pushed this in our faces. I'll make that clear. I'll never forget all you guys, because you guys put us through a lot of pressure, and especially with Tim Minton, you put me through a lot of pressure by kicking me out of the MCA board hearing for calling out the BS. Let's make that clear. I'm never going to forgive you guys, and that's a big middle finger to all you guys. So like I said, shout out to President Donald Trump, shout out to Trump, shout out to the Republican Party. I might, thank God they ended right now, because I would have switched parties. But shout out to the Republican Party for shutting this down. So take you and enjoy your day.
Thank you. Thank you. We appreciate it. Thank you. Thank you for your testimony. We're now going to go to virtual testimony. Angela Burns. Wait for the Sergeant at Arms to call time.
You may begin.
Hi, good morning. I'd like to thank the City Council, the Health Committee, in any support of Resolution 642 in relation to CDPAP. I am a licensed clinical social worker, but in this moment, I am testifying as a family, on behalf of a family member In relation to CDPAP, I am a designated representative in the care for my mom, and she has dementia, and we're trying desperately to make sure that she can remain at home after the death of my father, who was her primary caregiver. And given prior testimony, I won't repeat what other people have stated, hopefully, but also looking to having everything go into one FI makes absolutely no sense at all. I live on the eastern end of Long Island, and services here are already hard to come by because it isn't considered rural, but it is kind of rural out here when it comes to services for the aging. Also thinking about New York State as a whole, there are a lot of rural communities, and to expect everyone to try to go through one PPL, it already is very difficult to have to work, be the designated representative, and try to make sure that my mom has the appropriate care that she needs and deserves. We've already had long wait times. Everyone's trying to contact the PPL. Wait times on the phone are above 2 hours at this point. How are we supposed to provide any continuous care for people if we can't even get somebody on the phone?
Thank you. Your time's
No,
expired.
you can finish, just summarize the.
Yes, thank you.
please. Sure.
So again, I do hope that all of our testimonies are taken into consideration, and I do appreciate your time.
No, before you leave, this is just a resolution for us, but I want to make sure you've been in touch with Senator Gustavo Rivera and others in the state legislature to make sure that they push this on, because this is the resolution is to support their legislation, but, okay? Okay.
Thank you.
Sure, thank you. Peter Kowalski?
You may begin.
Peter Kowalski, are you there? Peter Kowalski? Okay, I'm going to call out these names. If you're present, please let us know. Ariana Osario. I know she's not. Dr. Craig Spencer. TK Small. Christina Garcia. Alex Clavering. Tara Thomas. Gordon Lee. Alex Stein. Is there anyone else that hasn't testified that wishes to testify? Please raise your hand on the Zoom function or fill out a card here if you're present in the chambers. That's it. We're done. Okay, so hearing none, I want to thank everyone, and I want to particularly thank Chair Moyer for joining me today in this robust hearing. We got a lot accomplished. There's a lot of more work that has to be done, and I appreciate everyone, including the staff and all that testified. So thank you, and with that, the hearing is now closed. Thank you.